A very good afternoon, and thank you to all the viewers that are joining in right now. I'm Dr. Nishkanov, and I would like to bid a warm welcome for joining us today as we discuss this topic, brain injury from falls in the elderly. And joining us today, we have the privilege to have our very own consultant neurosurgeon, Dr. Gurmit Singh. Good afternoon, Dr. Gurmit.
Hi, Kenneth, and hi to all the viewers.
Yeah, Dr. Gurmit, the brain is still the biggest mystery of the universe. And being a part of the Faculty of Anesthesia and Intensive Care myself, I've seen many cases of brain-related surgeries. So, Dr. Gurmit, why this topic today?
Kenneth, I didn't hear your question, but there was a lag there. But I think the question here that you're asking is why this topic specifically on the elderly. Did I get that right?
That's correct.
Yeah, it started from this patient that I had, a 75-year-old gentleman with heart disease on blood thinners. He had a fall in his living room and his right temple brushed against the edge of the coffee table. A small bruise, a bump, and the family quickly picked him up and sat him on the sofa. He recovered. He had lunch with them. They made small talk at the lunch table, and as was his habit, he retired for his afternoon nap. At 3 o'clock, the daughter peeps into the room, sees him asleep, sound asleep, and she is reassured. So at 6, she notices that this gentleman is not woken up for his dinner. So she goes into his room to wake him up, and that is when she notices he's no more responsive. So they rush him to the hospital, and I receive them in the hospital. CT scan shows a very large blood clot. We have a discussion, and the family decides to not to go for active management.
Right.
Now, this incident illustrates there's a need for the medical profession to highlight and share knowledge on head injury in the elderly, especially from benign, trivial falls. This need to sensitize the general public becomes more urgent when we realize the elderly, in Malaysia defined as more than 60, are currently numbering about 2 million, 6% of the population, will become 15% of the population in another 14, 15 years.
Mm-hmm.
Concomitantly, the burden of the geriatric disease also will increase, and in particular, falls in the elderly population will be a major social issue because it's very costly care. Worldwide, close to about 500,000, half a million people die per year, making falls one of the leading causes of unintentional death and injury. There's a lot of anxiety, fear about falls and head injury. Ask any elderly patient who has had a fall before, and they will relate how they have lost confidence and with it their independence. On the other hand, many are oblivious and do not care because they or their loved ones are not in this age group yet. Eventually, all of us will reach that milestone. And rather than have a tidapa attitude, isn't it best to be sensitized, educated, and become empowered so that on the day when you are in that emergency department facing the doctor, you are not overwhelmed by events, but you can digest the information that's given to you. You become braver, confident in interacting with the doctor, and best of all, making good decisions. That's the bottom line.
Right. Thank you, Dr. Gurmit. Yeah, I totally concur with you on how important this topic is. In fact, in many cases in our practice, brain surgery has become such an important aspect. What are the reasons contributing to falls, Dr. Gurmit, that we see in our daily population these days?
Let's for ease of understanding, let's divide this into reasons attributed to the patient and to the environment surrounding him.
Right.
So with patients, you look at vision problems. They have cataracts. Do they have issues with refraction? The glasses, the power is not good enough. Unsteadiness, balance issues, secondary to an earlier stroke, secondary to arthritis. They have slower reflexes, elderly. So muscle weakness, very common. It's difficult to wake up from a sitting position, be it from the sofa, from the bed, or the toilet.
Yep.
Side effect of medications that can cause lightheadedness, such as medications for the heart, hypertension, sleeping pills, sedatives, antidepressants. That's very, very common nowadays. Diuretics for heart and hypertension that will make you go to the toilet regularly, up and down, up and down.
Right.
Alcohol consumption is another dangerous thing. Then what about the extrinsic reason, the outside reason? Surface, the house is the marble is highly polished. The bathroom has got a very smooth surface. Or if you go outside, there's a downward slope. Inappropriate furniture height, very, very common. Sofa is so nice to sit, very plush. When you sit in, you sink immediately, but you have a tough time waking up from that sofa. Same thing with the height of your bed. Either it's too high for the elderly person or too low. So when you wake up, it's a big challenge for you. What about the dining hall set? The chair is a bit too high or a bit too low. So that this all needs to be considered. Lighting is another very, very important factor that I have seen myself. Footwear is the other very, very often neglected. You wear slippers, ill-fitting shoes, those factors.
Yeah. So from most of the reasons that you have explained to us just now, it seems many of them are modifiable. So, Dr. Gurmit, how do we prevent falls?
You hit the nail on the head when you said modifiable. That means we can correct them. And how do we start that? Will be first to educate the public, have discussions like this, so everybody is sensitized to it. Now, then we address the intrinsic problem and address the extrinsic problem. For the vision, get your cataracts operated. Change your glasses regularly. Have your powers checked periodically. And then muscle weakness will definitely, exercise will definitely help muscle weakness. Tai Chi is proven to really help patients. You can discuss with your physician, saying you're having this giddiness. Can you reduce my drugs? Can you change the drugs? It's very, very important that you should not suffer in silence. Highlight this to your physician. Discuss with your physician. Reduce the dose, change the medications. Now, extrinsic, this is where I noticed, even among my own family members, we have lived in the same house for the 10, 20, 30 years. You have become so accustomed to it, but you have aged. You have aged. The previous places that were no more challenge now are challenging for you. Your stairs, all that you have to consider. Let's start area by area. Let's start with the living room. Some of us have this habit of changing the layout every 6 months. You want to refresh the whole environment. But for the elderly, they have this. They have imprinted it already. So if you keep changing, it's a bit of a problem for them. Even patients with degenerative brain disease, Alzheimer's. So for them, it's very, very important that everything remains same. So that one. Next, adequate lighting. I agree. The yellow light in your hall gives a very warm glow, very nice look. But it's dangerous. So I strongly suggest that you have a proper lighting for the for your hall, especially. And then you might have the latest fancy AV system, but if the tapes are all on the floor and your elderly parent is likely to trip away, secure it, tape it to the floor. Another thing I've often seen is the edges of the carpet are uprolled, especially the aged carpet one. So that is very, very dangerous to them. So you need to tape that down. Remove. It's quite fashionable nowadays to have throw rugs. These are the smaller rugs, carpets that if you were to walk on it, you're liable to slip on it. So again, please keep that away from the hall. House might look beautiful, but you're endangering your elderly parents' life there. The other thing that I recall now is the height of the sofa chair. I don't think so. You're going to rush out and buy a sofa that's just suiting for your elderly parent, but have a chair that suits his height, his size, so that it's easy for him to get in the chair, easy for him to get out of the chair.
Right.
Um, the other thing that this concerning men with prostate problems, they have this problem where they have to rush to the toilet. Otherwise, they will void, they will soil themselves. It is extremely for them. It's extremely concerning. It's embarrassing for them. So,
Yes.
and they will do whatever to rush and reach the toilet, and that is where accidents happen. So, may I suggest that instead of having him go to the toilet, have him pee in a urinal and with a foldable screen, in the hall. So for his to maintain his dignity to privacy, you can unfold and void urine into the urinal, and then once done, you can have wet ones, clean himself, and that's it. Instead of him rushing to the toilet.
Yes. Very good.
Now the pathways in the house. If they are not brightly lit, then we are asking for trouble again.
Right.
So ensure that it's like stairs. When you go up the stairs, especially if it's poorly lit and you have got parquet on the floor, everything looks, the one step to the other looks the same. So I would suggest, I've done this for myself. I'm on the wrong side of 50 now, so I myself am being very, very careful. I apply colored tape on the edge of the stair, so that when I go down, I'm aware I'm going off to the next stair. Otherwise, all looks similar, especially when the light is not good. Everything looks similar, and you might trip and fall. So the edge of the stair, I've applied a tape, a different color tape, a red, blue, or whatever, so that it stands out. That's contrast for you. Ensure the part, the kitchen, the toilet room is white, not littered with decorative items, plants. In the room, this is where we really need to be focused on. Declutter the room. I don't think so. Your elderly parent needs all the decor items like that. So we want to make it fall proof and safe. Yeah, that's the priority. The height of the bed, again, just like in the sofa, it should be easy to get on the sofa, easy to get off. Here, similarly, easy to get on the bed, and it should not be a battle to get off the bed. At night, a night light will do. Really help out the elderly person. Or some people have this light where the movement triggers the light. It comes on. The light comes on.
Right.
And just like in the hall, why can't you have a urinal by the bedside instead of making this elderly gentleman walk all the way to the toilet? And nowadays there are urinals that we don't have to wash. They are disposable, made of paper. So in the morning you just dispose everything off. So there's no need for you to wash anything. Again, anti-slip shoes. I'm not very sure about these Japanese slippers where the straps are held between the big toe and the second toe. If the elderly person is having diabetes, cannot feel, they describe it as walking on clouds, walking on cotton. Because the ability to hold this strap is not that good. So the slipper keeps coming off, and their attention is they're trying to adjust that, and then they look down, and that's when they trip and they fall, they stumble.
Wow. So, how about flooring? Anything that we can
very important point in the room, especially where you are likely to fall. I would suggest impact absorbing tiles. They are available in the market. We can get them.
Impact absorbing tiles.
Yeah. This absorb the impact, so make the hopefully reduce the effect of the fall.
Right.
I have even suggested baby monitors to some patients, because instead of your elderly parent coming all the way to your room to ask you for help, why not have a baby monitor there so he can communicate with you directly?
Okay, or a call bell, maybe a small little bell.
A bell. Yeah. So that idea, I suggest to my patients when they go to the toilet. In the toilet, I suggest, I'm sorry, in the bathroom, you have a chair. If the patient is very fragile, Then you have a chair where the patient sits on it and takes the shower. Number
Right.
one. Number two, can have a bell in the toilet so that in case anything happens, this is one way where the elderly communicates with you and tells you he's in need of help. And
Yeah.
third thing is, very importantly, not to latch the door. You can
I
shut the
see.
door, maintain your dignity, but
Mm.
do not latch the door. So that in case there's anything, we won't waste much time breaking down the door. We immediately walk in and address the situation.
Well, Dr. Gurmit, there's so many modifiable factors that can significantly prevent such big problems in elderly. Um, when an elderly person is in their own home, uh, where would they normally slip and fall?
That the commonplace, the answer to that will be where they hang around often. So
All
this
right.
will be indoors and outdoors. Let's talk about indoors. When you talk about indoors, it'll be living room, kitchen, their bedroom, and the toilet. And outside, uh, I've got horror stories where elderly gentlemen, 70 plus, climb onto a rambutan tree at 6:30 in the evening to pluck
Mm.
rambutan for their grandchildren. One more went up the roof to adjust the aerial. Probably must be some football game, Manchester or Liverpool, something like that. That they had to climb up the ladder and go up to the roof and adjust the aerial. The third one that I very vividly remember is you do a DIY project, paint the wall, and you climb onto to a ladder.
Mm.
So that tells you that the in the house are the more fragile, the frail ones. The accidents that happen outside are the slightly more healthier ones that are able to move more freely.
I see. I see. All right. Just just to thank the ones who are coming in and still joining us. Thank you very much, and welcome to our webinar. Um, Dr. Gurmit, as we were discussing the previous question, where indoor versus outdoors, um, is there any difference in brain injury concerning the young and the elderly? What's the
Yeah.
difference?
The first there are a couple of differences. First thing is the type of injury. In the young, it's high impact, high energy, commonly seen in motor vehicle accident, road accidents. In the elderly, you're not going to get an elderly man sitting on a RXZ running around at 120 kilometers, nothing like that.
Right.
It is low impact, low height force.
Okay.
So one, two. More importantly, here is when as you age, the brain volume starts to decrease. So that at a rate of about 0.2 to 0.5% per year. So that by the time you reach 60 to 80, you've already lost about 6 to 11% of your brain. So that if I were to show this in my hand here like this is the skull, and this is the brain. So when you are young, there's not much space, everything very close by. All the arteries are not stretched like this. But as you grow older, the brain starts to fall away.
Mm.
It starts to fall away, and the vessels are stretched. One fine day, you had a knock, and this vessel gives way, and that bleeding occurs.
That plasticine you were showing is a blood vessel.
It's blood vessel. I'm demonstrating that how initially when you're young, there's not much stress on the vessel. So as
Yep.
you grow older, it starts getting stretched because it's attached one to the skull, to the skull structures, two to the brain. So as
Right.
you go older, it gets stretched and it, it,
Any
it
slight
ruptures.
trauma.
Yeah, any slight. I have heard the most trivial knocks causing bleeding in patients. So what happens is because of this available space in the elderly, they are able to accommodate this blood compared to a young person that there's no room to accommodate, and they quickly manifest symptoms. In
Right.
this elderly, there's a lot of space here, so they can accommodate much more blood. So therefore, the symptoms appear later.
I
So
see. Right.
therefore, giving rise to the phenomena of delayed deterioration or talk and deteriorate. Like this gentleman that I mentioned earlier, he fell, he bruised his right temple, he spoke to the family, he had lunch, and then went to bed and then deteriorated over time.
Right.
So the danger here is the caregivers will not be able to detect these symptoms and changes.
Mhm.
The patient is very commonly not able to voice out the changes happening to them. Many of them has Alzheimer's, they're elderly, they cannot tell you all this. Or they already starting to deteriorate, so they're not going to tell you anything like that.
That's
It's
right.
for the caregiver to observe this. And even if they notice changes, the caregiver have good rationale for this. Oh, he was gardening, he's tired, that's why he's sleeping. Oh, he had to walk around the taman today, that's why he's tired.
Mm,
Or he had maybe the food that he ate was not agreeable to him, that's why he's vomiting.
right.
So the third thing is, because of the space between the brain and the skull, there's a lot of room for the brain to move around. So therefore, if this is the skull and this is the brain, and it hits the skull, it will rebound backward. So that's a double whammy from the front and
Right.
from the back. It hits here and here into the skull. So you get coup. This is the coup injury, and when you rebound backwards, that's the counter coup. So it's a
Right.
double whammy. Front and the back get injured. Then, very importantly, nowadays, as we're having more elderly patients on blood thinners, we have blood thinners for any reason: heart disease, stroke, you have atrial fibrillation, artificial valve, DVT.
Mm.
Many of them have been prescribed this medication. Here, I want to
Medications such
reiterate
as,
again.
Dr. Gurmit, medications such as aspirin,
Very
cardiopin, Plavix.
exactly,
Yeah.
exactly,
Yeah.
exactly. Plavix, cardiopin, this aspirin, warfarin, all these drugs are blood thinners, and you really,
Right.
really need to be alert. I suggest any elderly patient on blood thinners with a fall best be observed in the hospital of 24 to 48 hours, where strict, repeated, and hourly observations are made. You don't want to lose any deterioration. Warfarin, for example, is associated with a almost 50% mortality rate in head injured patients. Along with the loss in cerebral in the brain volume is the fragility of vessels. That is why in patients with head injury, elderly especially, the brain matter within it starts to bleed. Why? Because the vessels are very fragile within the brain. And then the last thing here is, compared to a young person, the elderly would have had heart disease, lung disease, kidney disease,
Mm.
and this will definitely lead to negative influence on the recovery. So this will definitely retard
Right.
the progress recovery.
Okay. Dr. Gurmit, that we heard a huge vast difference between the elderly and the young population. I'm sure it's not just the brain that may have the vast differences. How about the other organs, other systems of the body? What other injuries that may complicate a fall?
Very good question, Kenneth. Here, I want to highlight again. Sometimes, if the fall is bad enough, you can have a cervical spine injury.
Right.
So, therefore, how do I rule this out? I need to ask my loved ones that, can you move your hands? Can you move your legs? Is there numbness? Have a look at behind. Is the neck swollen? Is it very tender to touch? Is it very painful to touch? Do not move the patient, because you're liable to make the injury worse. The first tendency here is to immediately pack the elderly parent and bring him to hospital. Now,
Correct.
here is where, if the injury is partial, you can completely transact the cord, or make,
Right.
basically, to make the injury worse. So please do not, I already told you what to look out for. Keep that in mind.
Yeah. So
Numbness,
cervical spine. That's the
yeah,
the
yeah, yeah,
most
yeah,
important thing that we have to look out for.
yeah, yeah.
Anything else?
So following that, you can have rib fractures. If you fell in the wrong way and hit the edge of the bed or edge of the cupboard,
Mhm.
hip fractures, pelvic fractures.
All right.
These are very, very important things. What's the significance of the hip fracture, pelvic fracture? This will make sure that you will be in hospital for longer. You're going to spend long time in hospital. You are exposed to other problems in the hospital. You are liable to get hospital acquired infection, and your luck is not good. You can get pressure ulcers. You can get a deep vein thrombosis. From that, you get pulmonary embolism. So this will is negatively impact on your recovery.
Right. Okay. So basically, a fall may not just be the brain. We have to
True.
look out at the spinal cord and every other systems. Um, let's say, Dr. Gurmit, we're talking about head injury today. So, when an elderly, just say a parent, um, at home and they fall, what happens next?
Let me divide this answer into where what happens at which place. So at home, at hospital, and then when we come back after you have overcome the acute crisis. Okay. Now, at home, commonly this is a low impact ground level fall where the patient falls out of the bed, stumbles down a chair or two, a stair or two, and strikes their head on the dresser, the bedpost, on the coffee table. In the geriatric head trauma, again, I want to highlight to you, when if you have an elderly family member on blood thinners and is above 60, 65, when you reach hospital, you must be triaged rapidly and assessed rapidly. If there's the other thing I need to highlight here again, frequently I encounter this is if there's a wound, the family applies pressure but keeps lifting the dressing to see bleeding stop, yes, no, yes, no, yes, no, and it keeps
Yeah,
oozing and it keeps oozing. So my suggestion to you is to constantly apply pressure. This area is very richly supplied with blood vessels. The
correct.
moment you lift it, it'll start to spurt again. The word I use is spurt because you will see it spurting like that, and that will it really scares people. You see the clothing all soiled with blood. So please apply pressure, and you will. I'm sure you'll be able to stem the hemorrhage. You'll be able to stop the bleed. In case it's only you and your loved one and you need to drive. So what you do is any material, your t-shirt, your long sleeve shirt or whatever it is, you tie it around like a bandana. Your tablecloth, you tie it around like a bandana. So at least that will stop the bleed. You don't want to bring the elderly patient with the blood pouring because you never know. So much of blood is lost, his BP will drop. You don't want that problem on our hands. Again, I must highlight here again: if you suspect neck spine injury, do not move your loved ones. The medical team will come with a spine board. They know how to move him onto the spine board very carefully. They strap the head between two blocks and move him safely to the hospital to be scanned. How do you identify again? I'll repeat this again. Weakness, inability to move one side of the body, numbness, pain at the back, pain at the neck. That's very, very important. Now you have reached the hospital. Quickly, please tell the hospital staff that your father is on a blood thinner. Have a list of all the medications that your loved one takes, and then we will take your blood pressure quickly, and we just like you stand on a weighing scale to get your weight. We have a scale that tells us how bad you are injured. This is known as the Glasgow Coma Scale, GCS. From the scale, we obtain the score, and it tells us how badly injured you are. So 15 is you and me. We can talk, lightly injured or maybe lightly injured. 3 is brain dead. So in between is where we will assess how bad you are injured.
All right.
Then we will go for the scan. Once you are stable, only then we will go to the scan room. Now, after the scan, that's when we'll see there will be 4 types of bleed. Now, let me demonstrate this with the skull model.
Fantastic.
Now,
nice.
if there's an injury here, so this is the skull.
Okay.
We'll remove this. You'll remove this. The first type of bleed that is just below the skull and above this leathery layer. This is known as the dural layer. Dural in Latin means hard. So this is a leathery layer. Also protects the brain. It also protects the brain. So one between the bone and the dural layer, the leather layer, the hard layer. So this is normally not a problem in the elderly. Why? Because the bone and this layer are very tightly adhered. There's no room for the blood to run through. So commonly, it's little amount of blood. We can handle that, not much of a problem. The major problem is contributed by bleeding under the dura. So it's known as subdural. This you have submarine under the sea. So this is subdural. So when I show you, I lift the dura. This is the blood layer. It's between the dural layer and the brain. So it's subdural. So this layer of bleed is dangerous. It's significant amount compressing upon the brain and causing symptoms, making you have less marks for the Glasgow Coma score than there's a need now to discuss, do we need to operate or not.
That's right.
Now, in case the blood layer is not that thick, it's a minimal amount, not causing much problem to the brain, then two things will happen. One, we'll observe you. As the days pass by, that blood can get washed away, can get resolved. So you're lucky, you're home free, no issues. Now, if while waiting, we see you're well, 4 5 days, the blood clot is not increasing, we'll send you back home. But with head injury advice. Of course, if you insist in staying in the hospital, then it's up to you. But we'll send you back with advice, because this clot can increase in size, not because more bleeding, but because of a reaction that occurs because of the blood. When it bleeds, this blood will release certain chemicals, will cause new blood vessels to form. These vessels are very, very fragile. So slight movement again, they bleed again. Then they release more blood, more chemicals are released, more new blood vessels are formed. So this is a vicious cycle. It keeps forming again and again. Very soon, within 10 to 14 days, you will see this increase in size. Not fresh blood, but altered blood.
Okay.
Yeah. So the operation changes. Like just now, if it's fresh, then we have to make a large cut here. That's a craniotomy. Cranio meaning brain, skull. Tomy meaning opening.
Right.
So for that, because the consistency of the blood is jelly, so I can't make holes to drain this jelly out. So I need to cut open and then slowly peel it off and wash it off.
I see.
It's become liquefied. I just have to make 2 holes into the skull and it'll come out. It'll drain out by itself. Then you flush it with saline and it'll come out. We can do this operation. Of course, the craniotomy has to be done under general anesthesia. But
right.
with the two holes, if you are very frail, you've got a lot of medical problems on board, you've got lung issues, then we can also do that under local anesthesia. What we'll do, we'll inject this area, numb this area, drill a hole, and then allow it. Of course, you'll feel the drill and all that. That is why this procedure under local anesthesia is only done for patients who can cooperate with us, who are a bit more alert. If you are in coma, you're agitated, then it's not safe. You will go under general anesthesia.
Right, right.
So the third type of bleed is bleeding within the brain because of the fragile vessels of the mentioned area. So you have bleeding within, from in the brain matter, in the cerebrum itself. Now, do you operate or don't operate? It all depends on the size of the clot, amount of mass effect, amount of pressure, and what is your score again. If it's small, we leave it be. It'll get resolved within 6 to 8 weeks. The final bleed is the one where the brain is bruised. Before I go to that bleed, let me show you the surface of the skull, especially the front part. You see, these are very sharp edges. If you can notice, the sharp parts, and this is the surface of the skull where the brain rests on. It's not smooth. There are a lot of ridges here. These are sharp. These are very sharp. So when the brain moves onto it, it gets lacerated. It gets bruised. So then you end up with situations like this. The lower part, which was resting on the sharp bits, on the ridges, they get bruised. So again, depends. If this is a large area, there's a lot of swelling, then we need to consider surgery. Because what is the consequence of that bruise? This whole part will get swollen. Once it gets swollen, then it'll compress onto the rest of the structures. So we probably have to do a craniotomy to give room for this part of the brain to expand. So, to put it in a nutshell, there are 4 types of bleed, each requiring different treatment.
All right, fantastic. Dr. Gurmit, how about patients that are on blood thinners? Will their blood thinners be stopped immediately, or?
Oh, yes.
Yeah.
Oh, yes. I must tell you that though you might be taking blood thinners for your heart valve or your cardiac stents and whatnot, when we stop this, which we must, otherwise, if you go to OT, the very first incision of the skull itself is enough trouble already. You will bleed. There'll be a lot of bleeding. So before I can do anything, I'm already overwhelmed by so much of blood. You lose blood, and as you are elderly, you have cardiac problem. You, it is bad for you basically. So therefore, I want to highlight that we will stop the blood thinners. We will give medication to reverse the effect of this blood thinners, vitamin K, FFP,
Right.
platelets,
Mm-hmm.
to reverse the effect. But therefore exposing you to the risk of your stents getting blocked, your cardiac valves getting blocked. So there is significant risk to that. But here you have to deal with the acute crisis first and keep our eyes peeled for any problems arising from the stoppage of blood thinners. Uh, I have told a lot of things thus far, but
Yes.
I we are now sitting in a very comfortable Saturday afternoon. Probably somebody sitting in the hall, somebody sitting in their room
Yeah.
with a glass of Starbucks. But but on the day when all this happens, there's so much of information thrown at you.
That's right.
The doctor's in a rush. He wants to go to OT to quickly address the problem. You have never heard some of these words, French, Greek, German, everything thrown together. Not to mention your mental state. Not to mention your
Mm-hmm.
auntie is calling from UK, one more uncle is calling from Australia. What happened to my lovely brother? These, that, what not, never ending. So suddenly your distant relative become your very close relatives. Everybody is concerned. Everybody is concerned. Here is
Right.
where I suggest you have a notebook, write down all your questions, clear your concerns, clear your confusion at the earliest. At the
Right.
earliest. Otherwise, you're overwhelmed.
Right.
You're overwhelmed, and this is bad for you.
Mm-hmm.
You get flustered.
Right. This, I guess, this notebook technique is very good for anyone who is going into the hospital. I mean, any case whatsoever, there will be so much of information thrown to you by the anesthetist, by the surgeon, by the physician, by the emergency physician. There's just so much. So I
Mm.
think this notebook technique, Dr. Gurmit, that's really pretty excellent. Um, Now that this patient came to the hospital, the neurosurgeon has done the operation. Um, uh, what is the pre-discharge plan? Just
Yeah,
when the patient is just about to be discharged, what's the
yeah.
plan?
So now it's just about to be discharged. I need to plan further. You have been under the care of the neurosurgeon, the nurses. Sorry, the nurses are very very important. You have got good nurses. You must have good nurses. Nurses, neurosurgeons, geriatricians, rehabilitation team with the physician, with the occupational therapist, with the physiotherapist, with the speech therapist, uh, dietitians,
Mhm.
psychiatrists, geriatric psychiatrists, psychologists. It's a team. It is a
Right,
team. It's never one person. It's never one person. It's always a team because this is a multifaceted problem. It's not just surgery and bye bye, see you later. Nothing like that. There are a lot of issues will crop up, and different specialties will need to pitch in to ensure that we get the best results. Now, you're about to go back home. It comes to my mind. I had this very nice, pleasant lady who was with me now for about a week, and I was planning to discharge her. So I called the family in for a meeting. Her four daughters stood in front of me in a semicircle. So I asked them now that she's about to go back. I need to train her how to feed her, how to bathe her, change the pampers, all
mhm,
things concerning her care.
right,
Who is going to take care of her? And almost in unison, they point to another lady standing next to them. I didn't notice her. Then I said, "Oh, sorry, are you the daughter?" And then the voice came from me, "No, itu menantu." So the look on her
landlord.
face, the look on her face was enough to tell me that, oh God, here I need to I address at this point
Mhm.
again, just like the doctors have taken care as a team, taking care of a head injured elderly is it's a tough job. It's a tough
Yes.
job. Get other families involved. Don't leave the burden to one person.
Yep.
What happens when you leave it to one person? That person eventually will burn out. And
Correct.
when he burns out, the quality of care goes down.
Mm.
Dark thoughts come to the person. Oh, I hope he dies. You know, I can't take this anymore, and this is bad. So eventually, other than taking care of the patient, we also need psychiatric care for the caregiver. So yeah, very very important. Many people forget about the caretaker. Like the earlier auntie, uncle from Australia, UK, everybody's asking, "How's my brother? How's my brother?" Nobody's bothered about the daughter-in-law or the daughter or whoever is the caretaker. So it's very very important. If you cannot, for whatever reason, care for your loved one, then you get a maid, hire a maid, and better to be done while the patient is still in the hospital, because you can bring the maid, we can train her.
Right.
We will train her how to change, how to wash, how to feed, everything. Or get a freelance nurse. Get a freelance nurse. If you cannot, then the nursing home is the way to go. Scout for a nursing home. That is why I always tell my patients beforehand, a week or two, so that gives you ample time to go all around to check. Now, nursing home is probably another subject for another webinar. It's a tough thing to do. I was working in one of the in the northern region, and I took the effort to see nursing homes around the general hospital where I worked. It was I visited 8 homes, all didn't pass muster. In the end, only one was good, purpose-built building. So therefore, you must go have a look around, see how many patients. Commonly, it's double-story bungalows modified. So you see how many patients per bed. The one that I visited, there were 5 patients in a bed, in a room. In the hall, there were about 8 beds arranged. It looked like a refugee center, like a so many people there. My question to you is, in case there's a fire, how do these people will exit the building? So there's no, I didn't see any fire extinguishers. You want to go, when you're looking at these places, go on a weekend, ask the family members around, how's this place, get testimony from people, speak to. Everybody will tell you, oh, I got in-house, the doctor comes regularly, I got physiotherapist comes regularly. Everybody will tell that. But in the end, it's very, very important to get testimonies from family members. That is really, really important, because you don't want to spend so much of money. In the end, one fine day, the nursing home has taken your loved one, dump them. I use the word dump here. Uncaringly put them send them off to a hospital with a big bed sore, with pneumonia, with blood poisoning, sepsis. That is it happens. I've seen many of this. It's dangerous. It's nasty. You don't want to go to a nursing home where cats are hanging around the furniture, dogs are hanging around. There's so much of dust on the furniture. The mattress is worn out. Holes in the sheets. Sadly, we don't have many step-down facilities in the country. So that's a sad thing.
But so these are small points that we can use to actually find a proper nursing home, Dr. Gurmit. I as you were explaining the about the caregiver, I realized that the caregiver takes most of the load. It's so much on the caregiver, the one person, or as what you have suggested, it's a team effort. And I totally concur with you that so much of money and so much of effort has been put into rehabilitate the patient from presentation into surgery, ICU care, and rehabilitation. And sometimes everything goes to waste when poor post-operative care is given. Coming out of the hospital, Dr. Gurmit, as the family brings the patient home, what is there for them to expect? What is the recovery at home like?
Let me draw an analogy of how you bring your elderly parent back home from hospital, and how you first brought your firstborn home from hospital. There was so much of joy. You have so many people around. The father and mother have gone before that to look for a baby cot. Same here. When you bring your elderly back home, If you can afford it, you want to get a motorized bed, okay. Otherwise, the normal bed is good enough. Then the parents will look for a very nice mattress. Same here, you are looking for a very good Ripple mattress. I rather you invest the money for the bed, 15, 20,000 for the motorized bed, uh, for the Ripple mattress. Get a quality Ripple mattress for 3, 4K,
Right.
and that will really prevent bed sores.
Big source.
And then, just like the father goes around town, every pharmacy looking for Snow 26 or some very fancy formula milk, same here, you will prepare formula milk for rice to for liquid
Correct.
diet. And then you went around town looking for Pampers, the good diapers, same here. You're looking for adult diapers. You want to prevent nappy rash cream, same here. It's similar, but the child will throw tantrums. Here also, there will be tantrums
Yes.
in the elderly. Cognition is already impaired and further compounded by this head injury. So, if after delivery, you're going to get your mother, sister-in-law, auntie, hire a maid, get a confinement lady, that means you need assistance.
That's
What
right.
about here? What about here? You bring back this patient is only left on one individual to take care. So I think it's a team effort, like you said just now. Definitely, family members need to be. I've heard all kind of excuses. Oh, I'm pregnant. I'm just recovering from a heart attack. Oh, I also had a fall. So it's a very dangerous situation. This is where you see the family dynamics coming
Right.
in. A broken family is a broken family, full stop. Father didn't give me property and this and that and whatnot. This is where everything bubbles to the surface. In the end, you're waiting for the family to take back the patient, sitting in the ward, sitting in the ward, sitting in the ward. This is very dangerous. Anxiety level is very high in the care providers. Again, like I mentioned earlier, the caregiver burnout is very real danger. Many people, first thing, do not recognize this. Second thing, do not give enough credit to the caregiver. This is nothing much. Anybody can do. Anybody can
Yep.
take care. The scenario, I've seen this also, is made really difficult if the patient has the diminished will to live. He's no more interested in living. Oh, that's a very sad environment. It's not often, but I've seen it, and it's very painful to see the patient waste away. I want to give a tip to family members. If you are in the general hospital, ask for domiciliary care assistance. Like in HCare, 10 kilometers around it, a team will come to your house. Not every day, not every day. They will first come a couple of times to give you the confidence to change the tube, to change the catheter, and give you more confidence. That is why I say it's extremely important while your loved ones in the hospital to quickly learn this art, the skill, so that when you go back home, you're very confident. I've had this response from a very a CEO of a very multinational corporation. He's asking me, how can you discharge my family member? He's not talking, he's not eating, he's sleeping all the time. I said, in the hospital, we only take care of the acute crisis. So as long as there's no further deterioration, the rest of the recovery takes place at home, in your care. That is why we want the family to be involved way earlier.
Right. Dr. Gurmit, any options on how far would the family go if there's a bleed in the brain in an elderly patient with so much of comorbids? Is there any tips, anything that you probably a will that can be written out before?
I recall these incidents where this high net individual got admitted under my care, and I saw the scan, and I said the outcome is grim. It won't be good. I think it's best not to do let him go in peace. I have to discuss these topics openly. There's no pantang here. So if the surgeon is going this way and that way, the message is not delivered to the patient. So therefore, it needs to be discussed very openly. So I said the outcome will not be good. The quality of life is not good. One group of children said, okay, yeah, we understand. Yeah, we understood what you said. Another set of children said, no, my father is a fighter. Whole life, he grew up from a very poor family. Now he's very wealthy. He's a very strong man. And so they chartered this plane and flew in a neurosurgeon from overseas. He came, saw the patient, saw the scans, concurred, and then the whole family came together and said, "Okay, done. We understand the prognosis," and then they let him go in peace. So it's very, very important that one, the surgeon conveys the news. Two, the whole family comes to terms. Otherwise, this is another flashpoint in family dynamics. The mother will say, "Okay, let him go." The children say, "No." There's big fight. The patient would have gone, but
Right.
this is a flashpoint, a starting point for another fight in the family. The family dynamics is the family is torn asunder, torn apart.
Yeah. Yeah. I think many of us can relate on certain incidents happening to our patients and their family. Thank you, Dr. Gurmit. This has been a very informative talk. We are taking questions right now. There's been a couple of questions that has been submitted through the Google form. The first question reads as such: My elderly had a second brain surgery to remove blood clot. The post-surgical care became challenging as she displayed signs of hallucination, speech unclarity, and restlessness. What can I do? And
This is
the second one goes on to say, can a head injury from fall cause or accelerate dementia? Your comments,
I
Dr.
think
Gumi.
I think both somewhat related to do with the behavior change. So post trauma. Here I want to highlight again that you can do two things here. One, it's okay, nothing much, head injury, consequences. Okay, we have seen this in some hospitals. They'll tie you down. They tie this agitated patient down,
Correct.
which is again dangerous, not done. That is definitely not the way to go. Here is where what I told earlier, this care of this patient is a team effort. The neurosurgeon will call in the geriatric psychiatrist, call in the geriatrician, call in the psychiatrist, call in the neuropsychologist to come, see, give their opinion, their specialty, they will contribute. Although the patient is sitting in my ward, in the neurosurgical ward, but this is where we will have input from the others. So therefore, the care is much, much more superior. Rather than saying, "Oh, it's okay, it's a consequence." Yes, head injury will cause this. There is frontal lobe syndrome, where the injury to the frontal part of the brain, we have frontal lobe syndrome, the patient will be shouting, screaming, will not be able to recognize you. These kind of things happen, but this is where you will want to get your psychiatrists, geriatric psychiatrists, psychologists, and the other team members. In the end, it's a team effort.
Okay. Okay. Great. Great. Can a head injury from a fall cause or accelerate dementia?
Let's answer this question. In a young person, severe head injury is a possibility to lead to a degenerative brain disease later, because nowadays they say head injury starts the process of inflammation. So inflammation will end up in degenerative disease 10, 15, 20 years later. Now, if you're already 70 years old, that effect probably will not be seen. But if you have frontal lobe syndrome, it can add on to your already Alzheimer's or your whatever degenerative brain disease you have, and that compound the whole situation again.
Okay. Okay. Another question we are taking in is after brain surgery, how long does the patient need to attend physiotherapy? And can we stop the physiotherapy if there's complaints of muscle pain?
I'll answer the second part first. If the patient's already telling you pain, please stop. You're not going to gain anything by continuing the exercise. So please listen to the patient. Number one. Number two, the question was, how long do you continue the physiotherapy? Am I correct?
That's right.
Yeah. So here, this is where the physiotherapist, the occupational therapist, the speech therapist, together with the rehab physician, structure a pathway for rehabilitation. They have targets to meet. They will know, okay, I've gone this far. Oh, I did not reach this far. I need to intensify this. I need to reduce this. So again, I highlight, this is where the rehab team comes in.
Okay.
Commonly, the common mistake here is, physiotherapy. No structure, no target, no plan. You invite somebody to come to your house, he shakes the legs, shakes the hand, moves the hands, moves the legs, the joint, that's it. But what's the target?
Right.
I want my father to sit up, to sit. So this is where a wholesome rehabilitative program is vital. And this will be done by the rehab team.
I see. I see. Okay, we are taking a question from Facebook from Natalie Chu. She asked the question: for a cervical spine injury, does the numbness and swelling manifest immediately, or will we have to wait for some time of not moving the elderly person?
It will manifest if the injury has happened and the cord, all the spinal, the nerves are injured, it will manifest immediately.
Immediately, yeah?
Yeah.
Yeah. So, can an elderly be totally paralyzed, Dr. Gurmit?
Oh,
And
yes.
if yes, what's the
I,
recovery like?
if you're talking about cord injury, are
Yes.
we referring to cord injury? If the
Both.
cord,
Yeah.
okay, let's talk about the cord. If the cord is badly injured, you'll become paralyzed.
Yeah.
You become
And there's no
paralyzed.
reversal to it.
Again, it depends on the amount of damage. Number one. Number two is amount of rehab that I put in.
Mm-hmm.
Structured rehab, not just come and do physiotherapy day in, day out, and don't have any targets, don't have any ambition. I need to reach this part. I need to push the patient. With regards to the brain, similarly, the recovery is directly proportional to the amount of effort, rehab effort you put in. Now, here I want to emphasize there's a golden period is the first 6 months. If you neglect this, recovery is not good. So in the first 6 months, intensify, you have everybody involved. That's where you see the improvement really go up. If you neglect this golden period, the next 6 months or next year, and then you wake up and say, oh yeah, I need to do something. You can. The recovery is not that great. By the end of the year one, then there's not much. By year two, don't expect any recovery. So the patient is the way he is.
Okay. We're taking another question. After brain surgery, how does the doctor check if there is residual blood clot?
You'll do a CT scan. Commonly, the practice is you do surgery the following day. We'll do a CT scan and see the amount of blood clot that's left behind. If there is significant amount of blood clot, or because of the blood thinness, re-bled again and causing more mass effect, then you need to go in again. We definitely dread this. We definitely avoid this, because the more times you go in, the danger to life, the danger to recover, the recovery is poor.
Right. Another question sounds like this: what are the symptoms of brain injury from falls?
Like I mentioned earlier, if the injury is bad enough, that patient is going to go into coma. I use the general term coma. He's not going to open eyes, not going to wake up. He's going to be quiet, lying on the floor or wherever you found him. So that's quite bad injury. Now the other injuries is the slow, the insidious one, the delayed deterioration, the top and deteriorate phenomena. There you need to watch out. They will slowly deteriorate. You will realize that he's starting to become sleepy. He's not responding to you. Even you tap, he opens eyes. The patient opens eyes, and then promptly goes off to sleep again. That many people say, oh, he's very sleepy. This is where I was telling you earlier. Oh, he did some gardening. Probably he's tired. Or he went around the taman. That's why he's tired. So you really need to be vigilant here. Third thing is with the acute, with the chronic subdurals, the one that there's a thin layer of blood that did not cause much effect, and we sent you back home and said, please come back in 2 weeks' time with a repeat CT scan. In these 2 weeks, that doesn't mean you are not cautious, you're not alert. The doctor's job is here to highlight to you what to look out for. If the clot is increasing, you will notice that your parent, your elderly, your loved one starting to have weakness in the arms or the leg. They will start to become more drowsy, more sleepy. They will not be able to eat or drink. They will start to drool. They will start to
Mm.
drool that way. Less active, less responsive.
Very good, insightful. Dr. Gurmit, we're taking a question from Facebook from Dina So, and she's asking, she's saying that she does not have any heart case or chronic diseases, but she found that she had a blood clot in the brain a year ago. She's still taking blood thinners. Is it necessary for her to carry on taking it?
I am surprised. Why is she taking the blood clot,
She,
the blood thinner again?
it
For what?
seems like
What?
she had a stroke 1 year ago. They found a blood clot in her brain, so she's still on blood thinners, and she's asking if she's is it necessary for her to take it.
It all depends on what caused the bleed in the brain. Was there any narrowing? Commonly, the blood thinner is prescribed to people with narrowed blood vessels. So they want the blood to be to flow easily, to be less viscid, to be less thick. That's why they give this medication. So the blood won't clot there, won't clump there. So blood can flow easily. So there must be a reason that your physician prescribed this blood thinner. If you were to stop, and then the blood might become thicker, might become viscid, and it will not be able to flow across any obstruction that is. So hence, here is for you to clarify with the physician: is there any blocks? How bad is the block? Where is the block?
Right.
Do I need to continue? It is important to know where the problem is and what caused that bleed.
Correct. So this discussion is best made with her primary physician that started her on
Definitely, definitely,
the
definitely. Here is
yeah.
where open communication with the physician is extremely important.
Correct. That's right. That's right. We're taking another question from Facebook, Pauline Tan. She has a very interesting question that asks, how does one get a brain stem stroke?
A very good question. You can get it just like a stroke in any other part of the brain, which is caused by rupture of the blood vessels. You have hypertension, you have abnormal blood vessels that they burst, they rupture. Thing can happen in the brain stem. The brain stem is very important part of the brain. Where it for me when I describe to a patient, I describe it as the CPU of the brain. All the cardiac center, the respiratory center, all are sitting there. Now, if you have a bleed there, commonly because of hypertension, it will damage these centers, and you might stop breathing, and you might have arrhythmias, problems in your heart, and such.
All right. The next question we are taking is from Evelyn Pang, and I've had this question asked to me many times when I'm taking consent before craniotomy to give general anesthesia to a patient. She's asking, what are the percentage of full recovery after brain injury in the elderly?
A very important, very important, interesting question. I always tell my patients, let's say, I'll just tell you, if I'll say 90% recovers, 10% doesn't recover. What? How do you know you're not in the 10%? Yeah, you think that you will want to be in the 90%, but what if you are in the 10%? Nobody can assure you of that. So many people are looking for guarantees. Many people are looking for guarantees. You spend 40 minutes explaining to the patient it's a complex surgery. At the end of it, somebody asks you, "Okay, doctor, thank you very much. I hope nothing will happen, right?" That's the final question. Nothing will happen, right?
Very
So I
true.
just spent 40 minutes explaining to you the risks and all that. And percentages, okay, many people quote percentages, but these are quoted from studies done overseas, not with Asian patients. These are quoted with studies done by Mahagurus who operated thousands and thousands of people. So their experience is what we borrow and quote you. the percentages. It is mostly it also depends on the patient itself. If you're 90-year-old going in for a craniotomy and you're 19-year-old going for a craniotomy, then the percentages also differ. There are all the other factors that can impinge on recovery. So coming back to her question again was, what was the percentage, is it, of recovery?
Yeah.
Yeah,
Percentage of full recovery.
or a full recovery. So all depends on the patient, on the extent of injury, and the location of the injury. If the brainstem injured, then there's nothing much to talk about. If there are certain superficial areas injured, then recovery is good. And if it happens in a younger person, recovery is good without any concomitant medical problem. You got atrial fibrillation, you got kidney failure, you got liver failure, then the outcome is not that great.
All right. Another question reads as such: what is the prognosis, and is it safe to do a craniotomy?
I think it's somewhat related to the
Yes, that's right.
earlier
That's right.
question. Okay, now let me
Is it safe?
e- if it's not safe, the doctor will not offer it. Number one.
That's right.
Number two, when you do this surgery, there must be benefit. So the doctor will discuss with the family. Like the earlier patient when I mentioned, 75-year-old gentleman, same thing like that. If the doctor thinks that that the outcome is not good, the prognosis is not good, the quality of life is not good, then I will advise my patients that, look, this is my opinion. I think the injury is extensive. You can operate, not issue. Anybody can operate.
Yeah.
But what will be the outcome? How long will you need to stay in the hospital? What will be the quality of life? Are you going to be bedridden? Are you going to have somebody feed you, change you, wash you forever? Are you going to be able to identify your wife? Are you going to be able to play with your grandchildren? Are you going to be able to go shopping?
Yeah.
That is important questions to ask.
We're taking a question from Facebook, and this will be one of our few last questions. From Evelyn Pang. She asked this question: is it true that all elderly above 70 be advised or prescribed blood thinners?
That's a very general statement. So
Yeah.
that's a very general statement. Not everybody will have to get a blood thinners. There must be some rationale for some reason: heart disease, stroke, artificial valve, cardiac stent, deep vein thrombosis. There must be a reason. Blood thinners must be treated with respect.
Yeah.
Uh,
It's not vitamins.
exactly, they're not
It's not
supplements.
vitamins.
Yeah,
Yeah.
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 Very
Yeah.
true. Very true. Very true.
We got a good question from Prishwin Kaur. Is arteriovenous malformation (AVMs) common, and how does it happen?
Arteriovenous malformation is equal to the artery, the venous, and malformation. Here, the commonly when you look at blood vessels, they are structured. They are going from this way, that way. They have a pathway. There is a road for them. But in here, this is a tangle of blood vessels. They're all meshed up. So you see one artery coming in, and it meshed up. It looks like a bag of worms, and then one vein. That's it. There's no structure here. So the surrounding area is not being perfused properly. There'll be a lot of issues there, and that because of this abnormality, the vessel walls are not the normal type of vessel walls. They rupture easily. They break easily. So that is why you get this so-called stroke. When you investigate a bit further, you find them, oh, it's abnormal blood vessels. These are the
Right.
arteriovenous malformations.
And the management is usually clipping of the.
Couple of things. Nowadays we got a good number of options: surgical, non-surgical. You go surgical, you clip them, you excise them. The other thing is you can embolize them. You can insert glue into them. You can block them, and then you can radiotherapy. Then you can do radiosurgery on them.
Fantastic. Fantastic. Okay. There seems to be no other questions that has been asked. So we would like to end this webinar right now. We want to just thank Dr. Gurmit again. There is uh, one more question actually. Dr. Gurmit, do you mind answering? Um,
Sure.
a question from Dominic Chu. Can brain hemorrhage be caused by a viral infection?
Can brain?
Hemorrhage. A bleed in the brain, can it be caused by a viral infection?
It is only if you have it causing an arthritis affecting the blood vessel. Then, otherwise, you have viral fever is highly viral, unlikely to cause any bleed within the brain. It must affect your blood vessels for it to rupture to break to cause problems.
Okay, all right. Thank you very much, Dr. Gurmit. Just before we end, we want to thank Dr. Gurmit again. He actually started his career as a general surgeon in Alostar, right, Dr. Gurmit? And in
Yeah, yeah.
2001, you joined Kuala Lumpur General Hospital as a neurosurgeon, training as a neurosurgeon, and you went on to National Neuroscience Institute of Singapore before joining the fellowship program in Australia. You've been the head of department in Penang GH, covering the whole northern region, and you've had a opportunity to travel to Paris and Istanbul to learn from renowned pediatric surgeons. And right now, after 6 years, 7 years in Kuala Lumpur General Hospital, you are now with Subang Jaya Medical Center as a resident neurosurgeon. So we want to thank you for your participation in this webinar this afternoon. We also want to thank you to all the viewers that joined in and logged in, and all the questions asked. We hope that this has brought about new knowledge that will help to prevent brain injury following a fall in the elderly. Thank you. Have a good day. Have a good evening, ladies and gentlemen. We'll be ending here.
Thank you. Thank you very much. Thank you, everybody. Thank you for your time.